Hi everybody, welcome to Pediatric Gastrointestinal Disruptions. Just when you thought you knew it all, here we are to talk about pediatrics. So exciting. So hopefully this won't be too terribly long. Again, we're just going to go over some specifics related to kiddos as far as GI stuff. So the first one we're going to talk about is dehydration. Etiology and pathology is going to be much the same as far as for adults. It really results from an abnormal loss of fluid. This will usually occur from the GI system. So when we're talking about dehydration, it's probably related to the GI system, usually related to vomiting or diarrhea to some degree. Either the person is vomiting up too much fluid, they're losing fluid, or they're really nauseous, they're not able to take in an adequate amount of fluid, or they're having diarrhea, obviously more fluid loss. So clinically it will happen whenever a total fluid intake is less than total fluid output. So makes sense, right? For children, it's the best way to measure a child's hydration status is going to be through body weight. And then you can kind of extrapolate from there how badly dehydrated they are. So if they're normally however many pounds they are normally, if you measure their weight and they have a 5% loss in body weight, especially something that happens very quickly in a matter of days, you're never gonna lose that much weight dieting. So that will generally be indicative of fluid loss and that dehydration is occurring. So mild dehydration is classified as a 5% loss in body weight. Moderate is going to be a 10% loss in body weight, and severe will be a 15% loss in body weight. As far as clinical manifestations and diagnosis, our signs and symptoms are going to include, we're going to be looking for weight loss. Obviously, we just talked about that. Unfortunately, an accurate record of weight before an episode of dehydration is not always available for comparison because kids grow fast, right? So it's not always, evident. They haven't been weighed on Tuesday and on Thursday they're dehydrated. We might not always be able to say strictly based on their weight that they are dehydrated. So other things we'll be looking for as far as skin might be cold, dry, because they can't sweat because they don't have enough fluid. So they might have cold skin, dry, might be grayish in color. They'll also have that loss of skin turgor. Their mucous membranes will probably be fairly dry. They might have chapped lips, kind of like that really dry looking tongue. Their eyes might be sunken in a little bit, and or the fontanelle. So especially in children who are infants, like you can see in this picture here, this is a picture of a sunken fontanelle. That means that child is really dehydrated. Of course, as adults and older children, we don't have that fontanelle. It is closed. But in little children and infants, if that fontanelle is sunken in, it's pretty indicative of dehydration. We'll also be looking for lethargic behavior, as well as for vital signs. They'll probably have some rapid respirations. Their pulse will probably be very fast, and it will also be weak. We call that thready, and their blood pressure will probably also be a little bit low. As far as diagnosis, healthcare providers generally diagnose dehydration on the basis of observed clinical manifestations. So if a child comes in and they have all of these things, or really any of these things, and they have not been eating or drinking very much, they've had any vomiting or diarrhea, it's pretty easy to say they're dehydrated. Laboratory tests are going to be done to confirm the diagnosis, also to help determine the severity. These might include serum sodium. So again, if sodium is, the particulate that we're talking about in blood, they might have a high blood sodium level because they are so dehydrated that their blood is really concentrated and full of sodium. So same thing, serum glucose, bicarbonate, and blood urea nitrogen. In general, weighing the child daily will also yield some useful information about the degree and severity of dehydration. And of course, hopefully when it starts to get better, they will start putting on that weight pretty quickly as well. Which brings us to treatment and nursing considerations. Really, our top priority is to identify and treat the underlying cause. So If they have diarrhea and vomiting caused by gastroenteritis, we need to treat the gastroenteritis, which we're going to talk about in a minute here. If at all possible, we should be encouraging oral intake as much as possible, clear liquids, the basics, right? So careful nursing assessment and interventions are going to be really important in the clinical detection and management of dehydration, especially in little children. We really want to prevent dehydration whenever possible. Of course, it's not always possible. If somebody gets gastroenteritis, it happens. But in general, we want to prevent it whenever possible. So we want to be encouraging that PO intake whenever possible. And then if a kid is nauseous, we want to make sure that we are treating that nausea before it becomes vomiting. And if they are having diarrhea, we want to be identifying the cause of that. Is it food poisoning? Is it a bug? What caused it? What can we do about it? Other nursing considerations, of course, monitor weight. And that's not supposed to say weight diapers. That's supposed to say weigh diapers. So I'll fix that. Especially in, the child who is still in diapers. How do we know how much fluid they're putting out? It's not like we can have them, void in a hat or a urinal. So we really have to weigh their diapers. Also, urine is a pretty good indicator of hydration status. In general, it should be that pale straw yellow colored. It shouldn't be dark or concentrated. It shouldn't have a foul odor. So if a baby is producing very concentrated urine, we should start to consider that they might be dehydrated. Other nursing considerations will be to monitor and to trend any labs. So again, that serum, that BUN, all those things. Monitor and trend INO, as well as vital signs. So hopefully if we start to resolve their dehydration, their vital signs will improve. Their respirations will become less rapid. They will have, they'll become less tachycardic, and their blood pressure will improve. Educate parents specifically that infants and children need more water, and they are more vulnerable to alterations in fluid and electrolyte balance. So just like the elderly, they are really vulnerable to any shift. They're not like us. At our age, we can generally rebound. We can be dehydrated for a day or two and come back from it. Children and the elderly really can't. They just become sicker faster when they are dehydrated. And then, of course, we're going to monitor for hypovolemic shock. So vital signs, and then further clinical manifestations of dehydration. If those worsen, we could be looking at hypovolemic shock eventually, which we would love to avoid. So I promised you gastroenteritis. Here it is. So gastroenteritis is a disturbance in intestinal motility. Fancy words, right? Really characterized by an increase in the frequency and the fluid content of stool, as well as the volume of stools. So generally when we see someone with gastroenteritis and diarrhea, they're going to be having very frequent bowel movements. They're going to be very watery, and there's going to be a lot of volume when it occurs. Diarrhea can be acute or chronic. It can be infectious or non-infectious. Diarrhea caused by an inflammatory process such as an infection is called gastroenteritis. So gastroenteritis, that's what we're talking about when we talk about like food poisoning or C. diff, anything like that. So although diarrhea can result from a variety of causes, the most common is going to be a bacterial or viral invasion. So gastroenteritis. The most prevalent bacteria pathogens are salmonella and rotavirus, especially in children. Poor hygiene, contaminated food, water, warm weather where, this bacteria can grow a little bit better. Crowded or substandard living conditions also predispose children to diarrhea. Infants have a greater susceptibility to diarrhea. Then the results are generally more serious because infants have a small extracellular fluid reserve. They just don't have enough fluid in their body to compensate when they start to lose it through diarrhea. Of course, the malnourished individual, the debilitated or immunocompromised child is also going to be more susceptible. Again, they're just more at risk, not only for developing gastroenteritis, but also kind of this sequelae that happens as a result, which is dehydration. They're more at risk for developing it, and they're generally going to have worse outcomes as well. Other things that can cause diarrhea can be diet. So food or formula sensitivities. Antibiotics can cause diarrhea, certain fruit juices, just certain foods in general. Some children are just really sensitive to a certain kind of food, and if you give it to them, they end up with diarrhea. So again, something like that is not gastroenteritis. It would just be classified as diarrhea versus gastroenteritis, which is related to an inflammatory process such as an infection. Signs and symptoms, probably don't have to go into too far detail with that. Increased number of stools and the increased fluid content of stools. Signs and symptoms of dehydration may also be present, so we just talked about that. As far as diagnosis, generally going to be made on the history of the person and their clinical manifestations. So as far as history, we'll be asking if they have been exposed to any new foods, weird foods, anybody else who has had a GI bug. That will help us kind of determine if this is potentially gastroenteritis versus maybe a food sensitivity. And then laboratory tests can go a little bit farther into that. We can do a stool culture, oviparasites, and a CBC. Again, in the stool culture, we're just looking to see if there's anything growing in there, right? Ova and parasites, because parasites can cause some forms of diarrhea. So something like Giardia, some people call it beaver fever. It happens generally in unclean water. All it takes is swimming in a pond and drinking a little bit of water by accident, and you can get Giardia, which is no fun. I've seen it clinically. They're never happy individuals. As far as treatment, our goal is going to be to restore fluid and electrolyte balance and, of course, treat that underlying cause. So oral rehydration is going to be really important. This is the best way really to get fluid back into a person, and same way for a child. So something like Pedialyte might be recommended by a physician. Water is really best. Pedialyte might be recommended if they're really considering that a child is losing electrolytes along with water. And then breastfeeding as appropriate for an infant who is still breastfeeding. That's going to be their best form of fluid intake. So breastfeeding, encouraging that whenever possible is always going to be good, especially if we're dealing with an infant who has diarrhea or gastroenteritis. Of course, hospitalization might happen. Generally will happen for severe diarrhea, probably with some form of dehydration going on as well. Usually they're going to end up getting IV fluid therapy. That's mostly the reason for hospitalization for a child with diarrhea and gastroenteritis. IV fluids will probably contain some form of dextrose because it will help provide not only fluid but sodium and calories as well. And again, depending on what's going on, a physician might order some additional potassium or other electrolytes to be included with IV fluid therapy. And then, of course, treating the underlying cause. If we know what caused it, if it's something like C. diff, man, I hope no babies get C. diff because that is a rotten thing to have. But if they did develop C. diff, we would be treating it with like oral vancomycin and doing all of those things. So treating the underlying cause is really important, and then kind of supporting that person, in this case that child, with rehydration is going to be our best course of action. Potential complications, of course, the things we worry about, dehydration, which we've talked about, renal failure, which we will talk about when I talk about GU, can develop as far as, especially a child getting very, very dehydrated. Eventually it starts to impact their kidneys. Metabolic acidosis, we talked briefly about. If someone is losing too many electrolytes through their stool, they can go into metabolic acidosis. Hypovolemic shock, usually what occurs after hypovolemic shock is going to be circulatory collapse, where this child just does not have enough fluid in their veins, and their veins collapse, and ultimately death will generally ensue. So of course, really, really important to prevent dehydration and prevent gastroenteritis and diarrhea in these kids. As far as nursing considerations, going to be much the same as for dehydration. You're going to assess and monitor their weight, their I&O, their labs, their vital signs. Make sure you're trending things so you're knowing, taking a snapshot of a vital sign doesn't do us much good. we really want to trend those. We want to know if that blood pressure is improving. We want to know if that BUN is improving. We want to know if their weight's going up. So trending is just as important as looking at any of these indicators as well. Of course, promoting rehydration, age-appropriate nutrition and hydration. So again, in the infant, that will recommend breastfeeding, potentially under a doctor's order, adding more fluid to a formula if they're bottle fed. In the older children, getting them some soup to drink, maybe some watermelon, cucumber, something high in water content. It doesn't just have to be water when we think about hydration. Of course, preventing complications. We would really love to do that. Offer emotional support to the child and the family is going to be really important, especially if that child is admitted to the hospital. That will be really, really hard on a parent. And in general, we're going to try and educate them to avoid antidiarrheals, because we really don't need to be giving a child antidiarrheals, and it can always go the other direction, and then you have a constipated kid, which is sad, which we're going to talk about next. And then, of course, preventing the spread. If there's any reason to think that this is an infectious process, we should be really discussing hygiene practice with the parents and instructing them on hand washing after changing diapers, and if it's necessary, potentially disposing of soiled bed linens, anything like that. And as promised, now we're going to talk about constipation. So on the opposite end, constipation is, of course, the passage of hardened stools. And it's probably painful. So if it kind of turns into this vicious cycle, especially with children. The first time they have constipation and they pass hardened stool, they may think to themselves, okay, well, that was really uncomfortable. I don't want to do that again. So now they're going to start to repress the urge to defecate. And this continuous repression will ultimately result in dilation of the rectum, reduced sensation, and a decreased muscle tone, which then results in chronic incomplete evacuation and severe constipation. So we really want to encourage the child to be passing stool whenever their body tells them they need to. They shouldn't be repressing the urge. That's a real good way to start them kind of on this cycle. Encopresis is the passage of liquid stool generally around constipation. So sometimes it's easy to think, okay, well, this child's really constipated and now they're having diarrhea. Oh no, we sent them in the other direction. But they might still be severely constipated, and now they're just passing liquid stool around that constipated stool. So they might still be having accidents or soiling, which again can, now they might be embarrassed if they're at that age, so they might start to repress the urge to defecate again. So constipation is possible at any age. We've discussed it in the older adult. Now we're talking about for children. Formula-fed infants might develop constipation as a result of high fat or protein content or an inadequate fluid content in formula. So, with formulas, you have to mix them with water. So if, great grandma can't read the container very well and gives, doesn't mix the formula appropriately, it only takes a couple days of that to really dehydrate a child, and then that can lead to constipation. For children, bigger children, medications and then the repression of the urge to defecate are going to be two major factors into the development of constipation. Again, so we want to make sure, there's that book out there, like, everybody poops, right? It's okay. We want to do it. It's good for you. So promoting that in children who are old enough to understand it, and always assessing for medications that might be impacting constipation. Clinical manifestations, of course, hard stool. If a child is passing hard stools, that's a good sign that they're constipated. You might see some bright red blood in stools. That might be indicative of some trauma. Perhaps anal fissures are developing as they're passing stool. The older child might complain of cramping, abdominal pain, of course, pain with defecation, anal fissures, loss of appetite, and irritability. I know for me, with my toddler, he would not eat for a day. And I'm like, what is going on? And it was because he hadn't had a bowel movement yet. As soon as he had a bowel movement, he was eating everything in sight. So that can be a good indicator of that constipation is happening if a child has a loss of appetite, because generally, I don't know, mine eats everything. So when he stops eating, I usually know he has to have a big bowel movement. And then irritability, because they generally don't feel good. Nothing sadder in the whole wide world than like a constipated baby who can't tell you that their belly hurts. So be aware of these things, especially for children who maybe can't describe what's going on. Diagnosis is going to be made by health history, as well as a thorough assessment of bowel patterns. Most children become fairly regular at some point, so any kind of deviation from that, hopefully parents are able to pay attention and perhaps tell you about it, and that could be your first clue that maybe they're getting a little constipated. And then, of course, the discussion of diet and medications. Are they eating a lot of cheese? Are they not eating a lot of fruit and vegetables? Do they not want to drink water? Are they on any medications that could be constipating? And then finally, a physical exam of the abdomen. I know we talked about it briefly, that occasionally you can actually feel hard stool in the abdomen, potentially also possible in a baby or a small child. Might include an examination of the anus or rectum just to see if there's any hard stool that's kind of stuck there. And then as far as treatment, for the infant, generally going to be to modify formula with more fluid or carbohydrates to help get things moving. Of course, if that baby is breastfed, just encouraging breastfeeding as much as possible. Mom's body, we'll learn about it in 109, is really good at reading a baby. We'll pretty much give that baby whatever they need. There have been studies that have shown, in a dehydrated baby, mom's breast milk will actually have a higher fluid content just to make up for it. It's kind of magic. No one really knows how it happens, but it's cool. So for little babies, for infants, modifying that formula, including more fluid under, doctor's supervision, and encouraging breastfeeding as much as possible. Maybe encouraging mom to drink more water. In general, breast milk will kind of do what it needs to do, regardless of mom's intake, but it doesn't hurt to have mom drink some more water. In the baby that's older than 5 or 6 months, we can potentially add in fruits, vegetables, increase fluid intake. There are occasionally some cases in a child that they will have just a tightened sphincter or stenosis of that anal sphincter, and parents will be educated in how to manually dilate that 2 to 3 times a day, and eventually it usually resolves on its own by doing that. As far as older children, again, what we just talked about, focusing on emptying the rectum completely. We might have to give them mild laxatives or enemas. Of course, that's not, where we want to go first thing. Really, we should be looking at dietary modification. So again, increasing fluid and fiber, potentially decreasing anything that's constipating, like cheese or whatever it is for that particular child. In the event that a child develops chronic constipation, we might have to do bowel retraining. This it generally involves the complete evacuation through enemas, stool softeners, manual disimpaction. So really getting that, colon, rectum, anus, getting it completely empty of any stool that could possibly be there, and then starting to add in behavioral modification with positive reinforcement. So again, pooping is good. That's what we want them to do. That is their job. It's okay to do it. It's okay to have accidents once in a while. The important thing is that they are moving their bowels regularly and completely. As far as nursing considerations, of course, we're going to assess, right? That's what we do. We're going to look at the abdomen. We're going to assess their bowel pattern, any stool characteristics that we're seeing. We're going to assess their diet, any medications. We're looking for any signs that this child is constipated and why that might be occurring. And then support and educate. So this is mainly for parents. A hard thing for me to remember when I'm raising my toddler who, likes to eat, but only wants to eat what he wants to eat, is that I'm the adult and I can put on the table what I want him to eat, and he can make the decision about what he takes from that. So encouraging that, not to always give in to what your child wants, that they're the adult and they make the food choices, and they can choose to offer more fruits, more vegetables, more water, the kid will live. They might not be happy about having to eat more fruits and vegetables, but if they're hungry enough, they will eat it. So including education around dietary modifications, what is normal for a child, and any medications, again, that could be constipating. If we're able to get rid of them, wonderful. More often than not, they're on them because they need it. So we should keep them on that and instead look at, other things we can do as far as dietary modifications, fluid, fiber, things like that. Important to note, make sure you're educating parents to avoid unpasteurized honey and corn syrup as a home remedy. These things generally, they used to be used much more commonly, but really they don't. At this point, it's mostly held that the use of these products can be associated with the development of infant botulism. So really, don't do that. They're not supposed to have anything unpasteurized, so don't even go there. If a family member or a parent mentions any of those to you, just guide them in a different direction, because that can lead to a whole nother host of issues. And then, of course, we've talked about bowel retraining, so I won't go into too much detail on that. Next up, we have GER, which is kind of like GERD, but not quite. So this is gastroesophageal reflux. It's the effortless regurgitation of gastric contents into the esophagus. So it's basically GERD, but it's just without the disease part of it in infants. Usually this will result from incompetent lower esophageal sphincter. So vocab words, regurgitation is the passage, again, of gastric esophageal contents into the oropharynx. So it's generally coming up into like the back of the throat. If any of us have probably experienced that once or twice, it's not fun. Versus vomiting, which is the expulsion of reflux gastric contents from the mouth. So regurgitation just kind of sits in the back of the throat, versus vomiting. Well, we all know what vomiting is. So in infants, this will usually begin within 1 week of birth. Regurgitation is generally going to happen immediately after a feeding. Sometimes if you lay an infant down after a feeding, they will regurgitate. So it's important just to know that it exists. As far as clinical manifestations, of course, vomiting or spitting up is going to be the primary manifestation within that first week of life. Aspiration of the gastric contents does have the potential to lead to respiratory signs like apnea, choking or gagging after feedings, and aspiration pneumonia. In young children, they might develop a chronic cough, wheezing, or recurrent pneumonia. Growth and weight gain might also start to, I won't say decline, but peter off a little bit because they're, not able, they're regurgitating more than they are actually digesting. Continuous irritation of the esophageal lining from the gastric acid can lead to esophageal ulceration and bleeding. If this occurs, it might manifest as anemia, blood in the stools, or blood and vomit. And as far as diagnosis, going to really begin with the evaluation of the health history and of growth and weight patterns. More invasive studies such as a barium esophagography, that's not a word, you know what I mean. Esophageal pH and an upper endo can be performed just to confirm that that's what's going on and it's not something else. As far as treatment, there's going to be conservative versus surgical. So of course, we're always going to try and start with the conservative measures. So feeding and positioning, we're going to encourage small, frequent feedings, potentially with a thickened infant cereal. Breastfed infants should drink expressed milk mixed with cereal, and a prone position will help improve gastric emptying. So again, we always, you'll learn more about this in 109. We always say, children should go back to sleep. They lay down on their back. But sometimes having an infant lay on their stomach after eating can help. It improves gastric emptying, also really reduces how much can be regurgitated. But of course, we only want to use this when the infant is awake and supervised, okay? So those are a couple things that you can educate parents on as well, for any parent who might come to you saying that their child has this, because it can be really frustrating. We're going to talk about medications on the next slide. As far as surgical management, it can be indicated in severe cases. usually a Nissen fundoplication, which we've talked about at this point, hopefully in live lecture. I don't know when you guys are watching this, but this will involve wrapping the fundus of the stomach around the distal portion of the esophagus to help prevent reflux of the stomach contents into the esophagus. This will be the most commonly performed procedure to help fix this if that's the way they decide they need to go. As far as treatment, hopefully at this point all of these medications look a little bit familiar to you from live lecture. So H2 histamine receptor antagonists work to reduce the amount of acid that's present in the gastric content and can really kind of help prevent that erosive effect of gastric content on the esophagus. Proton pump inhibitors also help reduce acid secretion. And in some cases, it can be possible to give Reglan before meals and at bedtime because it accelerates gastric emptying. So nursing considerations, support. This can be really kind of distressing to a parent because their itty bitty baby is just seemingly regurgitating every single thing that they put in. It can also be really frustrating to them. They might think that they're doing something wrong, and it's usually nothing to do with them. So they might just need some reassurance that this is actually a physiologic issue. It's something to do with that baby's, makeup at this moment in time. It's not generally going to be because of anything the parents are doing. So we're going to educate about the plan of treatment, any medications they might need to be on, and then going back to that feeding and positioning. And of course, signs and symptoms that they should report. If that baby is having anything respiratory related, they should report that to their pediatrician because they might have aspirated some of it and be developing a pneumonia. And then of course, bloody vomit or blood in stools might be indicative of the development of a GI bleed, which we want to treat right away. Prognosis, GER is usually pretty mild and normal function is going to be achieved by week 6 to 7. So usually it goes away after that. If it hasn't, almost all the time it will have improved by age 1 year. It doesn't usually go past that. But of course, if it is, that's when they'll probably start to consider, or if it's very severe, they might start to consider some surgical management of it. And then potential complications, we've talked a little bit about esophageal strictures, recurrent respiratory distress. So it can cause kind of some long-term effects if it's not dealt with as soon as possible. So something to keep in mind. Next, we're going to talk about intussusception. One of my favorite words. It's a really nasty thing to have happen, though. So intussusception is actually the most common cause of intestinal obstruction in children between ages 3 months and 6 years. It's actually twice as common in male children. And in general, there is no known cause of why it happens. It just happens. So it is technically the result of the telescoping of one portion of the intestine into another. So if you look at that picture, you can kind of see how the bottom part of the intestine kind of got sucked up into the upper part. That's what we call telescoping. So if you think of a telescope, how it starts, I don't know, I think of Pirates of the Caribbean when they've got that telescope that pulls out. That's what it is. And of course you can't see me and I can't draw anything, but if you're having a difficult time understanding what that is, try Googling it. I'm sure there's probably a good YouTube video that can demonstrate it a little bit better. So the most common site is going to be the ileocecal valve at the juncture of the distal ileum and the proximal colon. As the ileum telescopes into the colon, the passage of intestinal contents distal to the defect becomes obstructed. Ultimately, the mucosa of the intestinal wall starts to rub up against each other. This creates blood and mucus, which leaks into the intestinal lumen and eventually will result in what we call a current jelly stool. So this is feces mixed with blood and mucus, and it looks like current jelly. So it's this kind of dark red jelly-looking stool. And this is a hallmark sign of intussusception. If you ever see this, you should think intussusception. As far as clinical manifestation, so signs and symptoms are going to probably be sudden onset of severe abdominal pain. We might see a child kind of curl into themselves in the fetal position to help guard their abdomen. We'll probably also see vomiting and lethargy, as would be common with any intestinal obstruction. And usually within 12 hours from this developing, they will pass that current jelly stool, so be on the lookout for it. Diagnosis is going to be mostly made on clinical presentation. Again, if we see this and we see that current jelly stool, or, a family member says they passed this, stool that looks like jelly, they will usually say that like jelly or jello or something like that. That's a big sign. So that's part of our clinical presentation. Imaging, ultrasound, and CT scans may be used. They might show perforation. They might also show the intestinal obstruction, which can be caused by intussusception. And usually a barium enema, some sort of enema, may be ordered in order to look at it. But really, well, I'll talk about that in a second. So imaging of all three examinations may show a bullseye, quote unquote, representing the intestine coiled within itself. So it's kind of cool to see. So treatment. So usually an enema will be ordered. A barium enema might be ordered in order to diagnose it, but in about 90% of cases, this actually fixes the intussusception. So it's pretty great. So the force of that enema can actually force the telescope portion into the correct position, and then it's resolved. How neat is that? Surgical treatment, of course, if this enema doesn't work its magic, surgical treatment will usually involve manual reduction so they'll go in, they'll do an open surgery, and they'll basically pull it apart and hope that it looks great. If there is a part that has become non-viable, meaning it has lost function, it might be dusky or black, they will resect it. They'll just take it out and then do an end-to-end anastomosis, where they basically just put the ends of that piece of intestine together, and hopefully everything will work again. Especially in kids, they're kind of magic. They're awesome. They fix themselves a lot of the time, and they generally heal really, really well and really, really fast, and don't always complain a lot, which can be nice. Potential complications, of course, peritonitis, intestinal ischemia, so that's where, there's just been no blood flow to a part of the intestine, an infarct, perforation, shock, and of course, if this is left untreated, it is very possible for a child to die within 2 to 5 days. So it's very important that this is caught and treated quickly. As far as your nursing considerations and interventions, we're going to start with assessing. So we're going to assess the physical signs of intussusception and be assessing for any signs or symptoms that any of those potential complications are happening. We're going to educate parents about the diagnostic enema because it might correct this, which is wonderful. If it corrects it, beautiful. They probably don't need surgery. So after we give this enema, we'll need to monitor for the passage of the barium and the return of normal bowel sounds and bowel movements. Usually a child will be observed for 24 hours, usually inpatient, so they'll be in the hospital for at least 24 hours following the procedure just to make sure it doesn't happen again. As far as surgical, if surgery is going to be indicated, the child will be kept NPO, usually within an NG tube set to low suction just to provide that bowel rest. They'll usually get an IV fluid to make sure that we're giving them adequate hydration and electrolytes. And then as far as postoperatively, we're going to be doing all the post-op things that we do. So measuring vital signs, monitoring the operative site, and assessing for the return of normal bowel sounds. Once that peristalsis has returned, generally it will be appropriate to start gradually introducing oral feedings again. So that will be nice. And again, if it's left untreated, most patients suffer worsening, so they'll have worsening complications or potentially die of complications such as perforation, peritonitis, and sepsis. But of course, with early diagnosis and treatment, these serious complications can be avoided, and incident of death is actually pretty rare. So that is it as far as pediatric stuff. Anybody have any questions, just shoot me an email. I'll be happy to try and clear some stuff up. I know that was kind of quick and down and dirty, but I did want to get some pediatric stuff out to you. So that's all. Thanks, everybody.